for joining us and accepting our invitation. And we have with us Professor of Medicine from PhD Institute of Medical Science, Dr. Dinesh is joining. Really, thank you, Dr. Dinesh, for joining this evening. And we have with us Dr. Shweta, the postgraduate from the Department of Medicine, PhD Institute of Medical Science and Research, going to present, and they're going to discuss about the approach to liver disease. Over to both the faculties and the postgraduate to take over the further proceedings of this session. Thank you.
Thank you, sir.
Thank you, sir, for the kind introduction. And over to you, Shweta. We can go ahead now.
Yes, sir. Good evening, sir. Today I'm Dr. Shweta, second year postgraduate from PSG. Now I'm going to discuss a case about approach to liver disease. Yeah, 33-year-old male working as a Panchayat secretary in the Kumbakonam came with the chief complaints of yellowish discoloration of eyes and urine for the past 6 months, abdominal distension for the past 3 months, and bilateral lower limb swelling for the past 3 months, and breathlessness for the past 1 week. History of presenting illness. The patient was apparently normal at his usual state of health before 6 months, after which he noticed yellowish discoloration of eyes and urine, which is insidious in onset and not associated with itching, passage of clay-colored stools, and not preceded by any prodromal symptoms. And he noticed abdominal distension for the past 3 months, insidious in onset, uniform in nature, gradually progressive, painless, and not associated with reduced urine output, passage of any frothy urine, or periorbital puffiness. He also developed bilateral lower limb swelling, started at the ankle level and gradually progressed up to the knee level, which is painless. And he developed breathlessness for the past 1 week, which is insidious in onset, class 2, here, not associated with palpitation, chest pain, orthopnea, or PND. History of loss of appetite present for the past 3 months. History of weight gain of about 6 kgs present since the past 2 months. History of native medication intake present for 1 day. After noticing jaundice initially, they have taken some native medication for 1 day. No history of fever, chills, or rigors. No history of abdominal pain, nausea, vomiting, and loose stools. No history of passage of black tarry stools, coffee ground vomitus, fresh bleeding per rectum. No history of gum bleeding, easy bruising, or epistaxis. No history of altered sensorium, reversal of sleep pattern. No history of high-risk behaviors or tattooing, IV drug abuse, or blood transfusion. No history of recent travel or outside food intake. Past history, patient was initially evaluated at outside hospital and diagnosed with liver disease 1 month back, but patient was not compliant with the treatment, not taken any medications. He continued with and is not a known case of diabetes, systemic hypertension, CAD, bronchial asthma, CVA. No history of surgeries in the past. Sir?
Just go back to the first slide.
Yes, sir.
Just go even earlier.
Yes, sir.
So what is your comments about the age?
Sir, it's an young age, sir.
Yeah, so you have a young male patient.
Yes, sir.
Go to the next slide.
Yes, sir.
So now you have 4 symptoms, right? One is yellowish discoloration. Just read out the symptoms once again.
Yellowish discoloration of eyes and urine, abdominal distension, bilateral lower limb swelling, and breathlessness.
So when you see a young male with jaundice, with abdomen distension, lower limb swelling, and breathlessness,
yes, sir.
Even before you, what do you think is going on in your mind? What are you thinking of?
Sir, Some liver pathology.
Okay, liver pathology. And then even if you were to anticipate something in the personal history, what would you anticipate in the personal history?
Sir, alcohol history.
Yeah, so definitely because you see a young male with jaundice, abdomen distension, lower limb swelling, and breathlessness. Now you go to each complaint. So, what is the definition of jaundice?
Sir, yellowish discoloration of the sclera.
Okay, yeah, here's where the
And
paradox
skins.
is it sclera or something else?
Sir,
Is it sclera?
conjunctiva and
Yeah, so is it sclera or is it conjunctiva?
mucosa. Conjunctiva mucosa.
See, again, different books give different explanations.
Yes,
I think in some of the recent books, they're mentioned as conjunctiva and the sclera as a misnomer.
yes, sir.
So, regardless of whether you tell sclera or conjunctiva, you must quote the book from which you are quoting from.
Yes, sir.
Okay. So, based on his complaints
Yes, sir.
from young male jaundice, can you tell from the history whether it's the type of jaundice?
Sir,
How do
from
you classify? How do you classify jaundice?
sir, pre-hepatic, hepatic, and post-hepatic, sir.
So, what do you think? Considering all his age and everything, what do you think might be going on?
Hepatic, sir.
Possibly it's hepatocellular. There's no
Yes, sir.
evidence of itching, which you have already and click on the stool, which you have mentioned.
Yes, sir.
Now, when you mention abdomen distension, what are the
Yes.
common causes of abdomen distension?
Sir, fat,
Yeah.
fluid,
Hmm.
platus, pieces,
Platters. Yeah.
fatal
He
growth.
says, he says he's a male, so he's not going to be pregnant.
Yes, sir.
So, do you think he's obese?
No, sir. Is moderate build, but not
Okay.
obese, sir.
When you look at the cluster of symptoms the patient has, breathlessness, leg swelling, what do you think he has?
Sir, is in volume overload status.
Yeah, it must be ascites. Go to the
Yes, sir.
next slide. Next slide, the lower limb swelling. Yeah. So now you have mentioned lower limb swelling.
Yes, sir.
So can you tell me what are the forces in the blood vessel which retain, determine fluid in and out of the blood vessel?
Sir, hydrostatic pressure,
Yeah,
and oncotic pressure.
yeah. So what retains fluid and what sensors fluids?
Sir,
So which the
increase
hydrostatic
oncotic pressure will retain fluids.
retain fluid and hydrostatic pressure sensor fluid, right?
Yes, yes.
So one, you have the cluster of symptoms together, and then if you have a patient with isolated lower limb swelling, what is your differential diagnosis?
Sir, cardiac, heart failure.
Yeah, one is cardiac. Yes, cardiac
Yes.
etiology. Then
Sir, hypoalbuminemia.
okay, low albumin level. Yes, hyperproteinemia. Then
Sir, cellulitis, DVT.
cellulitis bilateral. Sometimes can.
Yes, sir.
Then
Deep vein thrombosis.
again bilateral lower limb swelling.
Sir,
Usually DVT will usually be unilateral most of
yes,
the
sir.
time.
Yes, sir.
So heart, protein. Then in this patient,
Sir, in this patient,
liver
hypoalbuminemia.
disease. Liver disease.
Liver diseases. Yes, sir.
What other organ?
Nephrotic syndrome.
Yeah, kidney.
Yes, sir.
Huh?
Yes, yes.
Any endocrine condition present in the neck?
Sir, thyroid.
Yeah,
Hypothyroidism mixed.
hypothyroidism. Okay.
Yes.
So, and then you spoke about breathlessness,
Yes, sir.
right?
Yes, sir.
So, what is the evidence? So, you said there's no orthopnea or PNT in this particular patient.
Yes, sir.
Then, what do you think is the explanation for the breathlessness in this particular patient?
Maybe due to tense ascites pushing the diaphragm, causing breathlessness.
Correct. So, it is the ascites, which is Okay, it is ascites which is possibly causing the breathlessness, right? Now you
Yes, sir.
spoke about New York Heart Association classification.
Yes, sir.
Can you just describe the class? What are the classes? Class 1, class 2, class 3, class 4?
So class 1, no limitation in the ordinary activities, sir.
Right. Good.
Breathlessness on more than ordinary activity.
Yes.
Class 2 is breathlessness at ordinary activity. And
Right.
class 3 is breathlessness less than ordinary activity.
Right.
And class 4 is at rest symptoms.
Good. Good. So,
Yes.
one way to generate, so from the, let's say you finish the parenting complaints, you can generate a differential diagnosis even before you
Yes.
go into the past history,
Yes,
right?
sir.
So
Yes, sir.
one way to do it is you combine all the cluster of symptoms together and come up with a DD. So what is your DD from the history you've seen so far? Just a probable diagnosis from the parenting illness itself.
Liver disease,
Okay, possibly
chronic
might,
liver disease, sir.
yeah. Okay, you might be dealing with a chronic liver disease with possible volume overload. Now, let us see
Yes, sir.
what your past history, your personal history has got on to add. Yeah, you
So,
can continue.
sir, can I ask a few questions up to now?
Sure. Yeah.
Again, Dr. Shweta, can you move to the presenting complaints, the history of presenting complaints, please?
Yes, sir.
So yeah, you said jaundice is a discoloration, and from this history, you said it is mostly hepatic. So what are the findings in the history, or questions, features in the history that make you point that it is hepatic and not either pre or post?
Sir, in pre-hepatic, there will be more of due to hemolysis, there will be unconjugated bilirubin.
Yeah, this is one common thing which you
Unconjugated.
tend to make. One second. So when we ask
Yes.
why you say it is hepatic, don't tell reasons why it is not pre or post. Tell reasons why you think it is hepatic first. Don't tell how you're ruling out. Tell how you're ruling in
Yes, sir.
first. So what makes you think this is hepatic first?
Because the yellowish discoloration of eyes and urine without itching.
Okay.
Yes.
Apart from the jaundice,
And
what else you have? You have from your history, it is ascites. So it is the hepatic causes for
yes,
jaundice, which when they progress, they decompose it and form ascites, which is not seen in
yes,
pre-hepatic or in post-hepatic. So
yes,
presence of jaundice and decomposition in the form of ascites points towards the hepatic cause.
okay, sir.
Right, so this
Yes,
answers your question. Why do you say it is hepatic in the first place and not either pre-hepatic or post-hepatic? So second thing,
yes.
how do you rule out pre-hepatic or post-hepatic?
In pre-hepatic, discoloration of urine won't be there, sir, because unconjugated bilirubin will bind to albumin and it won't be excreted in the urine.
Are you
And
sure in pre-hepatic you won't have yellowish discoloration?
of urines.
Okay, fine. Okay, so you'll have more other systemic symptoms rather of anemia rather than liver disease per se, right? You'll have symptoms
Yes,
of maybe a splenomegaly causing pain on the right left hypochondrium, which is of anemia. All that may be present, which
yes,
so far we know are not in this patient. Again, having a young patient with jaundice, we still need to think of those causes as well.
yes,
Why can't it be post-hepatic?
yes.
So post-hepatic, what do you think are the causes which can cause jaundice? Common conditions which you might see now
Sir,
and then.
gallstones.
Yes. Then?
Sir, cholangitis.
See, cholangitis is rather a complication of obstructive jaundice. But my question is, what are the common reasons for obstructive jaundice which you can come across? One you said is gallstones. Very well agreed. Anything else? Just one more will do.
Yes, sir.
One more reason.
Sir,
Malignancies.
Okay, sir.
Again, not something which we more commonly
Pancreatitis.
see in our medical wards, but still, these are the two conditions. What are the features against a post-hepatic jaundice in this patient?
No pain, sir.
So that is very important. The patient
Yes,
doesn't have pain.
Yes,
Or even if he's had pain, sometimes patients with liver disease, they complain of a vague, dull aching, diffuse pain, maybe because of distension or because of complications like SPP or something. But this patient doesn't have pain at all. So that is one
Yes.
feature which is against a post-hepatic or a surgical cause for jaundice. Second is again the presence of decompensation and long duration. Sometimes they don't progress for 6 months without coming to notice. They usually present earlier, especially in case of acute conditions like gallstones. They tend to present earlier with symptoms, and they tend to get intervened in some way, either with medical management or with interventions. They tend to get present early, not for 6 months. So again, in this history, you have mentioned that it was not preceded by prodromal symptoms. Yes, we commonly tend to ask this for any jaundice, but when you say the history has been there for 6 months, it is little unlikely that the patient might remember that before 6 months whether he had prodrome or not.
Yes,
So
sir.
maybe if it was a shorter duration, 1 month or 2 months, I think this point might be relevant. But
Yes, sir.
again, some examiners, they might ask you, you're saying the jaundice is there for 6 months, did the patient remember whether he had prodromal symptoms or not before 6 months? That some might ask, but you can still explain. I want you to be prepared for that question as well. One
Yes,
thing. Second thing is, in jaundice, especially when it's present for more than 1 or 2 months, you can also tell whether it is waxing or waning, because even in liver disease, based on the
Yes, sir.
alcohol intake pattern or other, it's because of other conditions like biliary obstruction and all, it can come and go. So maybe you can add that point as well. Again, this is a little tricky because when you tell that, they will tend to ask, where will you get intermittent jaundice? So that also you should be prepared. So I'm just telling one more point which you can say. So coming to abdominal distension, this one more point in the last line you have mentioned, not associated with reduced urine output. This is again, we tend to say that we ask this history to rule out kidney involvement, but ascites formation as such, the pathology is diversion from the urine, right? So invariably they will have some form of reduced urine output. If you probe and ask, they say, no, I don't pass urine like before. It has definitely reduced to a certain extent. So you cannot say that with the liver cause, the urine output is not affected. Or if at all it is not affected, then maybe the patient might be on medication. That might be one reason. So this maybe you can just probe and ask, and you can maybe refine. One more thing, and you mentioned the other causes of distension, right? So fat, feces, flatus, everything. So relevant to that, maybe in distension you can add one more point, whether it is relieved by passing flatus or motion. In this case, it may not be relieved, right? So you can mention that one point here, so that you know you're ruling out other causes of abdominal distension.
Okay, sir.
Okay. And lower limb swellings are discussed in detail. So breathlessness, just one more point. I think this is more from the medical aspect. You said NYHA, right? I think some examiners might ask, with the history itself, how do you know whether it is cardiovascular or respiratory, and why do you choose NYHA rather than that MRC's grading? I mean, that is one thing which I remember from my MD days, examiners asking. So you should have some justification why you chose NYHA for this particular patient. So, and breathlessness in this patient, you listed only one reason. Ascites causing, raising of the diaphragm, leading to breathlessness. Any other reason which you can think of from the history, from this point?
Sir, hepatopulmonary.
And you should notice that it is there for only 1 week.
Yes, sir. Sir, complications of CLD, DCLD, like hepatopulmonary syndrome, or
Again, tell the common thing first. How often do you come across hepatopulmonary syndrome? What else is more common in liver disease in the lungs? You said ascites. What can happen? You have ascites, you have lid swelling. Where else can you get fluid again?
Albumin is low.
I've asked you very directly. Where else can fluid accumulate, causing breathlessness?
It's a pulmonary edema.
Do you get pulmonary edema and liver disease? Again, this is how you take the exam in another direction, not the direction which you want.
Yes.
You have ascites,
Yes,
you have
sir.
leg swelling.
Yes.
Male patient, you can even have scrotal swelling. So my question is, where else can fluid accumulate, leading to breathlessness?
In the lung, where can it accumulate, Dr. Sweta? Outside the lung? Where? What is
Sir, in
surrounding
the
the lung?
pleural effusions.
Yeah.
So pleural effusion.
Yes.
So the bottom line or the take home is, think
Yes,
of
sir.
common things first.
Okay, sir.
Okay. At
Yes, sir.
any level of questioning, think of the common things first. So first thing is, after you tell ascites, it is going to be pleural effusion. One way which you can classify this as breathlessness and CLD, you can say causes related to underlying liver disease, causes unrelated. Related
Okay, sir.
would be ascites causing distension and raised diaphragm, pleural effusion. Then
Okay, sir.
comes your complications like hepatopulmonary syndrome, portopulmonary hypertension, which are not very common. Yes, when we follow patients for a long duration and we with other history and examination only, we come to those conclusions. But from the
Okay,
history, it's
sir.
very difficult to say whether it is HPS or portopulmonary hypertension. Again,
Okay,
on
sir.
the other side, just for the completion, I'm asking, what are the other unrelated causes which can cause breathlessness in a cirrhotic patient? You see, it is there only for 1 week. Imagine patient is now there in the ward. In the current situation, what other causes you will think of?
Sir, infection or pneumonia.
What infection? Patient is there in a medical ward. You've been seeing him for the past 2 or 3 months on and off. Now he's come with breathlessness. You have ruled out by clinical examination, he doesn't have much of fluid, only moderate ascites, but he's breathless. So what other things you think of? I'm telling he's now in the ward. What reasons for breathlessness currently you're seeing more and more in the ward now?
LRTs.
So you should also think of LRTA. So what common reasons can they present with? I mean, what infections you think of?
Sir, viral influenza.
Atypical viral in the current
Atypical.
scenario, that is very well common, one thing. And even bacterial can also happen. Incidentally, they might have picked up some community-acquired pneumonia. So that also
Yes.
you think of.
Yes.
Anything other than infection? Though there is no history of orthopnea PND,
Yes.
any other reason for breathlessness, which you should also have in mind?
No.
Cardiac and renal.
Yes,
Though
sir.
the patient doesn't give history of orthopnea PND,
Yes.
he can still have an underlying, maybe a heart failure with preserved ejection fraction or something like that, which can lead to breathlessness. And also, liver patients, any day they can go in for a renal failure, which can also be the reason for an acute breathlessness. So,
Okay, sir.
this is something, see, this is not just for the exams I'm telling you. When they present with breathlessness, you see them in the EMD or in your OPD, or you see them after getting this coming to the ward, these are the things that should run in your mind.
Okay, sir. Okay, sir.
And this one history of weight gain of about 6 kgs, how do you think it is important? Why
Sir,
is that?
because of fluid
Accumulation. So
Yes,
that is going to be one of our goals in management. We have to reduce that, because that it'll improve his quality of life. He can start working again. His
Yes.
appetite might improve. So
Yes, sir.
this should be borne in mind when we see as how we are going to treat this patient.
Yes, sir.
Okay.
Yes.
Okay, you can proceed now, ma'am.
Okay, sir.
Quick question.
Yes, sir.
Now, in this male with jaundice, can it be prehepatic with a chronic liver disease?
Sir, congenital.
Is it congenital? So
Sir,
let's assume there is pallor and there is prehepatic, there is jaundice and there is chronic liver disease. Which condition? See,
Wilson, sir.
Very good. Yeah, Wilson's very
Very
rarely
good.
is associated with hemolytic anemia.
Yes, sir.
Also, you can have an autoimmune liver disease with an autoimmune hemolytic anemia. See, sometimes these things can coexist.
Yes, sir.
So need not be a pure hepatic, can still be coexisting hemolytic anemia as well. Yeah, continue.
Yes. Personal history: patient consumes mixed diet, history of reduced appetite present, sleep pattern normal, bowel and bladder habits no alterations, alcohol history: patient consumed 60 grams of alcohol per day for the initially for past 2 or 3 times per week for the past 6 years, followed by 120 grams per day daily since the past 1 year. Last intake was 1 week back, and the Cage score was 4. No history of smoking. And family history: patient
Please,
belongs.
1 second. Go back to that.
Yes, sir.
So I'll give you three options, Dr. Sweta.
Yes, sir.
You have 330 ml of 5% beer.
Yes, sir.
Okay, 150 ml of 12% wine.
Yes, sir.
45 ml of spirits, 40% spirits.
Yes, sir.
Which one is better in terms of alcohol content?
Sir, spirits as 40% of alcohol content, sir.
Why? See, it's 40% alcohol, 45 ml.
Spirits is highest. Yes, sir.
They're all the same, Dr. Sweta.
Yes, sir.
See, the percentage of alcohol in each one of those things varies.
Yes, sir.
Beer has more volume but less alcohol.
Yes, sir.
Wine is in between beer and strong spirits, but it's 12%.
Yes, sir.
And you have hard spirits, which is your rum, whiskey, brandy, which is like 40-45%.
Yes, sir.
So they're all similar,
Yes, sir.
except that the spirits are more concentrated.
Yes, sir.
So you spoke about the Cage score.
Yes, sir.
Can you elaborate on what is the Cage score?
Sir, cut off, patient and annoyed, feel guilty, and eye openers.
Yeah, that is.
When sir, sir,
Yeah, sure.
one second. I just want to add on, sir. Sir, Dr. Shweta, sir, ask
Yes.
your question. Elaborate. So first, tell
Yes,
why
sir.
are you using Cage score, and tell the complete question that you asked. What is cut off? What is annoyed? So answer in complete sentences so that the examiner knows that you have read well and you have also applied it well. So first, tell us what is Cage score used for. Start like that.
Cage score is used to check persons to check for abuse and dependence of alcohol, sir. To check for.
Okay, so that you can tell as a first line, and then you can say there are 4 questions which we ask, and what
Yes.
are the 4? Now tell in this way to sir. Yeah.
Yes. Uh, uh, to ask for ever felt to cut down on drinking, and second question is have people annoyed by criticizing your drinking, and third question is have you felt guilty about drinking, and fourth one is uh, uh, have you ever felt you needed to drink first thing in the morning, like eye openers, or to get rid of hangover?
So based on this questionnaire, how do you assess whether patient is having alcohol use disorder or not?
Patient is
You said the score is 4, right?
yes.
So what is your interpretation from that?
Patient is having alcohol use disorders.
So based on what number you will say alcohol disorder is there or not? That is my next question.
More than
You say
2,
patient
sir.
score is 4, so you say patient has alcohol use disorder. Agree.
Yes, sir. Yes,
So what the score was 2.
2 or
So that is my question. So
yes,
yes, complete.
it's
2
2
or
or higher. 2 or higher means the patient is having AUDs, alcohol use
So
disorders.
anything more than one, it means patient has alcohol use disorder,
Yes,
right?
yes,
So
sir.
this is a very simple question to assess problematic drinking, or in other words, alcohol use disorder or not. Or
Yes, sir.
if it is high, it means patient has a high chance of relapse towards alcohol after he stabilizes his medical condition. So that is why we ask this in all patients.
Yes, sir.
Okay.
Yes, sir.
So again, regarding the alcohol content servers asking question, right? So I would like to add one point, sir. Luckily for us, most of the patients who come with alcohol problems, they take hard liquor only. So it is easy to calculate. So how do you convert this grams from ml? What is the conversion? You know that?
Yes, sir. The ml, total ml in into percentage of alcohol content into the density of alcohol is a
You're
constant
going too much
0.8,
into
sir.
physics and formula. Very simple question. So why is it important to know in grams? Sir told only in ml and the percentage, right? Why is it important to know in grams? Because the dosing of the liver disease, I mean, based on what dose patients liver disease or pancreatitis and all, it's
Yes, sir.
based on grams per day only in most of the literature so far. So that's
Yes,
why
sir.
we need to know,
Yes,
right?
yes, sir.
So you would have read, right? So what do
Yes,
you
sir.
think is the dose to cause alcoholic liver disease in patients?
Sir, in men more than 40 to 80 grams per day, and in female more than 20 to 40 grams per day for a period of 10 to 12 years.
Again, this is varied. Sometimes it is, I mean, as far as I remember, it is 60 to 80 for men and 40 to 60 for women.
Yes, sir.
And the grams per day, agreed, for a duration of 7 to 8 years is sufficient. Again, this varies from textbook to textbook. Harrison says in a different way. Our liver textbooks, Sheila Sherlock, and all tells in a little different way. But you
Yes,
should
sir.
know that 40 to 60, 60 to 80, different for men and women. One
Yes, sir.
thing. The next question is, you also have a safe limit.
Yes, sir.
Do you know what the safe limit of alcohol is? That comes in a different unit
Yes,
and
yes.
duration. What is that?
Sir, for men less than 30 grams.
No, it comes in a different unit, not in grams. I mean, it might be then, but what we follow is units per week. Less than 21 units per week for males and less than
Yes, sir.
14 units per week for females.
Yes, sir.
Okay.
Yes.
So the next question is, how do you, this is all for hard liquor only. So
Yes.
how do you convert roughly from ml to grams and unit? Very simple formula you should know. 30 ml, 10 grams, 1 unit. This is the conversion.
Yes, sir.
30 ml, 10 grams, 1 unit. Some books say 8 gram also is 1 unit.
Okay,
But
sir.
you can understand this way. So to know more, you should also know how much the patient is having, how much is 180 ml, how much is 270. So that also from the history you should know to
Yes, sir.
calculate the dose that he takes usually daily. So
Yes.
that is one thing from this history you should elaborate. And
Yes.
you said that clearly for the 6 years his intake was only 60 grams per day, 2 to 3 times per week, and
Yes.
for the past 1 year it increased to 120
Yes.
daily. So this change in
Yes.
habit only most of the cases they precipitate alcohol hepatitis. For the previous dose itself, he may be having an underlying alcoholic fatty liver or a mild hepatitis for quite some time. But when he suddenly changes his drinking habit, when he goes to a higher level of drinking, or when he sometimes binge drinks, you even have a definition for that. That is when alcoholic hepatitis or acute onset of or a jaundice precipitates. Till then, he'll be having a very you take an ultrasound for most of the alcoholic patients. They'll have subtle changes or mild electric changes. But when their behavior of alcohol changes, that is when they present acutely to most of us.
Yes, sir.
So that is probably a reason why it happened even 6 months ago. And because of continued alcohol intake, and we develop the next complication only, he's come to us. So that is from this history, what we should know. Okay.
Yes, sir.
You said about CADE score. Any other score you know of other than CADE score for assessing the
Audit score, sir.
Yeah, that's a bit elaborate, but just tell me how many questions you ask.
So 10 questions.
Yes, fine. That's a little elaborate, but at least you should, knowing it and applying it regularly should be fine.
Yes.
Okay. So any more questions from you, sir? Sorry, I had to
Yeah.
interrupt.
Yeah. So how much does a standard drink contain? How much grams of ethanol?
Sir, 30 grams. Small 30.
No, standard drink is 14 grams of ethanol.
Okay, sir.
Standard drink, as I told you, is 330 ml of beer, 150 ml of wine, and 40 ml of spirit.
Okay, sir.
The next question is, what is binge drinking?
Sir,
If you don't know, you can say you don't know. I can answer.
yes.
Yeah, binge drinking is basically 5 drinks in 2 hours for men and 4 drinks in 2 hours for women. A standard
Okay,
drink
sir.
contains 14 grams of ethanol,
Yes, sir.
and the blood alcohol level goes up by 0.08 milligram per liter.
Okay, sir.
This has to be differentiated from heavy alcohol use. What is heavy alcohol use?
More than 120 grams.
Now, heavy alcohol use is defined in terms of drinks. Binge drinking on at least 5 days in 1 month. Binge drinking is for 1 day. Heavy
Yes, sir.
alcohol is binge drinking at least 5 days in a month.
Okay, sir.
Or you can also define it as more than 4 days for men and 3 days for women on any most days of the month. Okay, so there are various gradations.
Okay,
You
sir.
have binge drinking,
Yes,
you have
sir.
heavy alcohol use, and then you have alcohol use disorder. Alcohol use disorder. If how do you diagnose alcohol use disorder beyond Cage's criteria? Okay, you have
Yes,
something
sir.
called substance use disorder criteria, which is applicable not only to alcohol but also to tobacco, drugs, and all that. If
Okay,
at
sir.
least 2 out of the 11 criteria come positive, then you diagnose alcohol use disorder.
Okay, sir.
Another important thing is once you elicit the alcohol history, you must also elicit other drug history. So alcohol and smoking can
Yes, sir.
also be you have elicited the smoking history, but also other drug history.
Yes, sir.
Sometimes opioid abuse, weed, marijuana. Sometimes all these things can also happen. Drug abuse can also happen.
Yes, sir. No such history, sir.
Right. Okay. Yeah, you can continue.
Family history. Patient is born out of lower middle. Patient belongs to lower middle class family. Born out of non-consanguineous marriage. No history of liver disease in the family. Nutritional history. Patient consumes about 1,800 kilocalories per day and 50 grams of protein per day, with a deficit of 700 calories and 60 grams of protein.
I just have a question. How did you calculate this 1,800 calories? How did you calculate them?
So for carbohydrate, 1 gram, 4 kilocalories.
But how do you know what is the number of carbs in a particular dish? And did you weigh the dish? Or how did you reach these numbers?
And I used some SPM book for that.
So you took a photograph of his diet.
No, so I asked his diet history.
So how did you estimate the content or the weight based on the diet history?
Sir,
It's not possible. See,
Yes,
unless
sir.
even looking at it, you can't, unless you don't weigh it.
Yes, sir.
So do they ask you to put up these kind of graphs for, I mean, this tabular column for nutritional history? Dr. Karthikeyan?
So actually in a DM, we expect them to go more into the details of their calorie intake. And again, that is roughly basically, for example, one idli is around 50 calories, one bowl of rice around 50 or 100 calories. So roughly we do have a calculation, but I think for MD level, you need not go into the details of your calories and protein intake. Your just one line mentioned that his appetite is reduced is sufficient. So
Okay,
I
sir.
don't think you have to go into the details of the calorie intake and protein intake in
Okay,
the
sir.
MD level is not needed, is what I would say.
And also, like she's mentioned 50 grams of, how can she grade with 50 grams
Yeah,
of
again,
protein?
that's
Just like
very
this is that.
tricky to say.
Yeah, so
So
Okay, sir.
yeah, you
yeah.
can continue. Yeah.
Yeah.
Excuse. Summary: a 33-year-old male with alcohol use disorder presented with a history of yellowish discoloration of eyes and urine for the past 6 months, and abdominal distension and bilateral lower limb swelling noticed for the past 3 months, and breathlessness since past 1 week, without history of fever, abdominal pain, GI bleed, or altered sensorium.
Dr. Sweta, you might just have to alter the summary. It should not be mentioned like this.
Yes, sir.
So you're using colloquial words.
Okay,
So
sir.
what you should do is young male
Yes, sir.
with alcohol use disorder with insidious onset of jaundice and features of volume
Yes, sir.
jaundice for 6 months and features of volume overload
Okay,
uh,
sir.
with ascites and possible fluid accumulation in the possible effusion in the lung. Uh,
Yes.
uh, you can say with features of insidious onset of jaundice, with ascites, with
Yes.
recent onset of respiratory difficulty for the last 1 week. So basically, you can't use the same words. You'll have to use what are called semantic qualifiers, which means you remove actual literal values of age and you just label it as young or middle-aged or elderly, and you put it as insidious onset, and then you don't mention yellow, you use the
Yes, sir.
medical term jaundice, and abdomen distension, bilateral volume swelling becomes volume overload, and breathlessness becomes recent onset of
Yes, sir.
respiratory distress. Uh, and that's how you need
Yes.
to, because basically you're trying to match your clinical summary with the textbook information. So it has to be reworded in
Okay,
that
sir.
manner.
Okay. Okay, sir.
Dr. Karthikeyan, any comments?
No, sir. I agree with what you say. You can slightly modify rather than using the same terms which you've used in the history. You can modify slightly and you can present the summary.
Yes, sir.
So I agree with sir in this.
Okay, sir. So, a young male with a alcohol use disorder presented with jaundice and
Insidious onset.
insidious onset, presented with jaundice with insidious onset, and volume overload,
With followed by features of volume overload.
and with respiratory distress since the past 1 week, is with features of volume overload, without any history of uh, fever, or any
You
GI
can say
bleed, or
without systemic symptoms, bleeding,
without any
symptoms of
systemic
blood loss. Yeah.
complications or symptoms.
You can say without systemic complaints,
Yes.
bleeding complications, or central nervous system manifestations. You just give it a broad label. Okay, yeah, continue. Next slide.
Yes. Yes. My provisional diagnosis. The probable system involved is the hepatobiliary system, and the probable diagnosis with the
Your voice is
related
breaking. Yeah, just speak into the mic, Dr. Sweta.
form of ascites and
Yeah.
jaundice.
See, again, your provisional diagnosis
Sir,
must cover every
sorry,
single
sir, I
complaint.
can't hear.
You're not able to hear me, eh? Hello, Dr. Sweta?
We are not able to hear you, Dr.
Yes,
Shweta. I think your connection is, I think it's not.
sir, sir.
Yeah. Now, can you just repeat the diagnosis once for us?
Yes, sir. The probable system involved is hepatobiliary system. The probable diagnosis chronic liver disease with portal hypertension, and the etiology is ethanol related, and the decomposition in the form of ascites and jaundice.
See, again, in your diagnosis, you must come up with a differential diagnosis
Yes, sir.
and you must explain every single complaint. Like, for example, okay, this could be chronic liver disease, but then what is the differential diagnosis? Are you sure it's only from the liver? You're not considering anything else?
So maybe because of cardiac, maybe
Yeah. So somebody with ethanol, what can happen to the heart?
dilated cardiomyopathy.
Oh, yes, it can be a dilated cardiomyopathy. So why can't this be a dilated cardiomyopathy with congestive cardiac failure and a congestive hepatomegaly and ascites and volume overload and jaundice? So
Yes.
basically, you can tell how will you argue?
So
No,
what
no.
sir has told, Dr.
Yes.
Shweta, what do you
Yes,
think
sir.
are the points in your history which favor and which are against? That is our question. Answer it that way.
Yes, sir. No symptoms of orthopnea, PND.
Exactly. Yes. Yes. So, so you should say, yes, I'm thinking first of chronic liver disease. Number two, since there's alcohol history, I'll think of a dilated cardiomyopathy and congestive cardiac failure, but there is no orthopnea, no PND. So it's less likely to be a DCM, more likely to be a chronic liver disease.
Yes, sir.
Okay. Now,
Yes, sir.
is there any evidence to say nephrotic syndrome with volume overload, anything like that?
No issue of reduced urine output or facial puffiness.
Yes, and also you wouldn't find jaundice generally in a nephrotic syndrome,
Yes, sir.
unless it's a liver
Yes,
disease
yes,
causing jaundice. Okay, so always you should come up with 2, 3 differential diagnoses with the most likely diagnosis in front, next likely diagnosis second, and third likely diagnosis third.
okay, sir.
Okay.
Okay, sir.
Now, does your diagnosis cover everything? This doesn't explain the respiratory distress. What about the respiratory distress? What's your theory behind the respiratory distress?
Maybe due to dense ascites.
That is one thing we discussed. What is the other
Yes.
thing which Karthikeyan sir mentioned? What
Yes,
can
sir.
happen in the lung?
Pleural effusion.
It can be a hepatic hydrothorax. So
Yes, sir.
so you have to bring that. So you have to give an explanation for the respiratory distress as well.
Okay, sir.
Okay.
Yes, sir.
Yeah. Continue.
So a few questions from the diagnosis, sir.
Yes. Yes,
So
yeah.
sir told that, yeah, if you think of other DDs, and sir mentioned other systems, like apart from hepatobiliary, sir mentioned whether it could be DCM, what are the points for and against, and nephrotic and hypothyroid. Even in the liver, do you think, other than CLD, any other causes which can present in such a way? Again, this might be slightly more than an MD well, but again, you will see, once you finish based on bio, you may be seeing patients like this. So, other than a decompensated chronic liver disease, any other ways, I mean, any other diagnosis you want to consider? You say patient has decompensated cirrhosis.
Yes.
Any other, I mean, entity or any other diagnosis you want to put forward apart from underlying chronic liver disease? Alcoholic hepatitis can present like this, though maybe not a duration of 6 months duration of jaundice, a shorter duration of jaundice. And alcoholic hepatitis can also decompensate transiently. They can have ascites, they can have leg swelling. So alk hepatitis is one feature that you should entertain. Next is acute on chronic liver failure or ACLF, which we keep seeing more and more nowadays, either because of acute alcohol intake or superimposed viral infections or other systemic causes like systemic infections or other issues. We see ACLF. So even within the liver, apart from DCLD, you can think of other entities like these two. One question, which is like slightly out of the way. Do you know anything called non-cirrhotic portal hypertension, Dr. Shweta? Have you heard of that?
Yes, nonce.
So is there a chance that this patient might be having that? Any points which make you think that it might be an NCPF or non-cirrhotic portal fibrosis like what was called before?
No.
Yes. Okay.
With
Let me tell you.
ascites.
Yes. You want to say something?
No, sir.
Okay, see, non-cirrhotic portal fibrosis or portal hypertension, the predominant feature will be portal hypertension. So the patient should have had some sort of a UJ bleed in the past, or
Yes,
at least at presentation. So that was not there.
yes,
And NCPF, mostly, even if the liver function is or the liver structurally appears normal, sometimes they do present with mild jaundice and ascites also. So when you see a patient with jaundice and ascites, rather than thinking of only CLD, think of these other possibilities also. Of course, the diagnosis, more than clinical, it is going to be based on investigations and other imaging findings, but also have all of this, because all of this will have an implication. You manage an underlying chronic liver disease is now decomposed in a different way. You manage as hepatitis in a slightly different way because patient is more sick. They are a little toxic. They have systemic symptoms. They are more. They have an SARS like picture. ACLF, on the other hand, they are all the more critical. They have organ failures. They become comatose. So they most often land in the ICU. So I think even at an MD level, you should know how to prognosticate your liver disease, or to how to classify your liver disease, whether just a stable liver disease which is slowly decompensating, or an acute insult in the form of either ALK hepatitis or an ACLF, that you should know. And in this, coming to this particular patient, you have mentioned that it is CLD with portal hypertension. From your history that you have mentioned
yes,
so
sir.
far, what are the features of portal hypertension that you came across?
Sir, ascites, sir.
See, again, this is a little contradictory, because most of the examiners may not agree ascites only as a feature of portal hypertension. So what history should, I mean, it's not even history, it's more of an examination finding, should be present to say that the patient has portal hypertension, which may not be there at the history stage.
Splenomegaly, sir.
Yes, presence of splenomegaly, umbilical veins are
Yes,
the classical features of portal hypertension, but without this from the history, without
yes,
a bleed,
yes, sir.
only with ascites, you may
Yes, sir.
not be able to come to a conclusion of portal hypertension from the history. Ascites, it is a feature
Okay, sir.
of both decompensation, and some books say portal hypertension also, but it is more a feature of decompensation rather than portal hypertension. So with only ascites and jaundice, you can rather entertain decompensation rather than portal hypertension. Again, very technical terms or theoretical terms which some examiners might be fond of asking. Okay. So
Yes, sir.
you mentioned that decompensation in the form of ascites and jaundice.
Yes.
So what are the features to say patient has decompensation?
Sir,
Not talking about history. Generally, when do you say a patient with liver disease has decompensated? What are the features? History, examination, investigation, all put together, I'm asking.
ascites, jaundice, hepatic encephalopathy, and varicose bleeding, sir. Presence of
One more.
and hepatorenal symptoms.
Before all that,
Yes, sir.
coagulopathy. So, like you mentioned, ascites, jaundice, encephalopathy, coagulopathy, and bleeding viruses, and sometimes as an extension of ascites, hepatorenal syndrome also. So, all these only technically mean decompensation.
Yes, sir.
Okay.
Yes.
So, yeah, I think this is about the diagnosis that I want to discuss. I think now we may proceed. Sir, any more questions, sir, from your side?
No, she can proceed. Yeah.
Okay.
You can proceed, Dr. Smita.
Yes, sir. The patient is conscious, oriented, afebrile, tachypneic at rest in both sitting and supine position, ictus plus bilateral pitching pedal edema up to knee level plus, and no pallor, clubbing cyanosis, generalized lymphadenopathy, and sarcopenia. Vitals and anthropometry. BP 110/70 mmHg measured in right upper limb in supine position. Heart rate 70 per minute. Regular.
One second, Dr. Sweta.
Yes, sir.
If you were to get lymphadenopathy, what's the significance between lymphadenopathy and abdomen examination?
So, TB, tuberculosis.
Right.
Peritonitis.
Tuberculosis. Yeah, you can get lymph node enlargement where?
So, TB, there might be generalized lymphadenopathy.
Okay, then you might find cervical lymph nodes, inguinal lymph nodes. Okay, what is the other connection? Lymph nodes and abdomen.
Lymphomas.
What about left supraclavicular lymph node?
Yes, sir. Virtuous node is in J malignancies.
Which one?
In G malignancies, sir.
GA in pelvic malignancy. Okay.
Yes, sir.
Okay. And what about the nails? What can happen in the nails? Go back to the general examination.
Yes, sir. Clubbing.
Clubbing. Nails, what can happen in liver disease?
Leukonychia, sir.
What is leukonychia?
Sir, white, white
Whitish
nails.
discoloration of
Yes,
nails. Huh?
yes, sir. Yes, sir.
What are the types of leukonychia? It can be spot-like or it can be linear.
Yes, sir.
It can be entire nail or partial.
Yes, sir.
Other than liver disease, what other conditions can produce leukonychia?
Sir, leukonychia is due to hypoalbuminemia, sir.
Beyond that,
Malnutrition. Sir.
okay, it can happen in zinc deficiency.
Yes, sir.
It can happen when the nail gets injured.
Yes, sir.
Sometimes fungal infection.
Yes, sir.
What do you look for in? Forget liver disease. In GIT examination and skin, what is the correlation? Okay, what is tylosis? Have you heard of the word tylosis?
No, sir.
It's thickening of the palm and soles,
Yes, sir.
palmoplantar keratoderma. Any idea what is it linked with?
Sir, no, sir.
Okay, it's linked with esophageal cancer.
Okay, sir.
There's a particular gene involved. Please read about it.
Yes, sir.
Now, did you comment on the hair of the patient?
Yes, sir.
How is the hair? Oh, it's coming
Sir.
here. Huh?
Yes, sir.
Okay, yeah, you go ahead and then we'll continue. Yeah, just go ahead with the next. Go to
Yes.
the previous slide and continue. Yeah.
Yes. The heart rate is 70 per minute, regular, normal volume, no specific character, no radial or radiofemoral delay. All peripheral pulses felt equally. SpO2 97% in rumor in both supine and sitting position. Respiratory rate 22 per minute. And
One
abdominal.
second. What is the comment on the respiratory rate?
Sir, smile tachypneas.
Yeah, he seems to be in some respiratory distress, sir.
Yes, sir.
But saturation is?
Normal, sir, 97%.
Is he using the accessory muscles of respiration?
No, sir.
Okay, yeah, continue.
Yes.
Just one question here, sir. Are they allowed to tell saturation in the examination? Because this happened for us in RDM exam. When the candidate answered saturation, he was actually caught. Why do you tell something which you use a gadget? So is that needed? Do you go for saturation in the examination?
That's a good question. That's a good question. Yeah, I don't think they'll be allowed. I think better not to
Yeah,
put.
I don't think you have to go for saturation. Yeah, we do that regularly in our workup assessment. But
Yes,
when it comes to examination, I don't think saturation, even if it's a respiratory patient, you don't go for saturation. So please don't mention that. Okay, it'll.
Okay, sir.
Either you will be asked by you,
I
sir,
agree with that. I agree with that.
you will be getting more questions.
Yes.
Yeah.
Yeah, this happened to one of my friends in his exam. So that's why I'm very, very particular when they say saturation in the examination. You present in the ward rounds, we are happy. But in the clinical examination, don't bring in saturation. Okay?
Yeah, I think
Everything okay. Everything else is okay, but not.
Correct. Yeah. So temperature?
Yeah. Okay.
Sir, temperature normal, sir. JVP 8 centimeter.
Okay. What is the definition of fever?
Sir, temperature of more than 100.4 degrees. 100 degree Fahrenheit.
Sure. Okay. In Harrison, it's 98.9, 99 in the morning and 99.9 and beyond 100 in the evening. It's a diurnal variation.
Yes, sir.
So what controls the temperature? See,
Blood,
they'll ask you all these questions, hypothalamic temperature set point, how infection, how cytokines produced by bacteria, viruses reset the set point,
yes, sir.
how methods of heat dissipation and heat conservation. How does body dissipate the heat? Okay, so
Yes, sir.
so you have rigors and you have vasoconstriction. So,
Okay, sir.
so in general physiology, there's an entire chapter on temperature conservation and dissipation.
Okay, sir.
Okay,
Yes,
so
sir.
you have to read about all that.
Yes,
They'll
sir.
also ask you the difference between pyrexia and heat stroke. What is the difference between heat stroke and pyrexia? Fever.
Sir, heat stroke, temperature of more than 106 degree.
No, but what is the difference in the mechanism? Heat stroke is something completely
something from
external
yes, sir.
temperature.
Yes, sir.
Fever and pyrexia is something internal.
Yes,
The
sir.
temperature, so that is because of heat outside.
Okay, sir.
Okay, this is something they'll ask you.
Okay, sir.
Yeah, continue.
JVP 8 centimeter water with intact abdominal
No,
jugular.
1 second.
Yes,
I like to stop you here itself. Is it 8 centimeter of water or something else?
H2, sir.
Sorry?
8 centimeter of H2.
8 centimeter of?
H2.
What are you measuring
Is
in
it
that
the
8
height or is it
centimeter?
water?
What fluid is there?
H2.
What is there in the inside 8 centimeter? 8 centimeter. See, you say mmHg, that itself is wrong. Millimeter mercury. So there, what do you exactly measure? Mercury, right? That column
Yes.
only you tell it is millimeter mercury.
Yes, sir.
In this, in the JVP, in that 8 centimeter, what
Yes.
is there inside? What fluid is there inside?
JVP stands for what,
In
Dr.
the
Sridhar?
vein.
Sir,
Blood.
jugular. Yes, sir.
Blood column.
Yes, sir.
So you have blood. So it is 8 centimeters blood. So in other simple words, don't tell what or blood. Just say it is 8
Yes, sir.
centimeters.
Yes.
Don't
Okay,
invite
sir.
more questions.
Yes, sir. Okay, sir.
Okay.
Okay, sir.
And for your knowing, I'm telling it is blood. It is not water. Because
Okay,
what
sir.
is present inside is blood.
Okay, sir.
Okay.
Okay, sir.
Any fluid, when you say the pressure, you say that particular fluid, centimeter of blood, millimeter
Okay,
of
sir.
mercury. So it
Yes,
is
sir.
never water. Water doesn't. I mean, the most abundant thing is water only. But what is that is the blood.
Okay, sir.
Okay, so
Okay,
just
sir.
till 8 centimeters. Okay,
Yes,
or
yes.
in other words, so I think we can just say it is elevated or not. So, or should they actually measure that column until I'm just asking, sir, Dinesh, sir. So, is it
Yeah. It is just a vertical height.
because
It's not about the water or blood. It's the height of the blood column.
Okay, sir.
yeah, so
Yeah.
I think some examiners will be happy if you just say it is elevated or if the veins are prominent. I mean, I don't know, sir. I'm just asking, do they need to actually tell the measurement of JVP, sir?
See, sometimes what they'll say measure the CVP. So the vertical height, yes, it has to be measured in terms of a value. For CVP, we tend to add 5. So sometimes, that can kind of give an indication about. So yeah, we have to measure the vertical height. It has to be measured.
Measured. Okay. So when you elaborate again, the questions might go, how do you examine, what question you kept, what all you use. So you should, I'm not asking all that, but make sure you're thorough with all that. And
Yes,
you
sir.
mentioned that there is intact abdominal jugular reflex. So
Yes.
what do you mean by this?
Sir, by giving
What
pressure
is your interpretation?
pressure over the abdomen, the
Where?
JVP
Abdomen where?
in the epigastric.
You're sure or you're guessing?
Oh, sir. Over epigastrium.
Okay, fine. Go on.
So what are the conditions you've ruled out? In a positive, what are the conditions producing a positive abdominal jugular reflex?
Sir, cardiac conditions.
Like
Right heart failures.
basically constrictive pericarditis and restrictive cardiomyopathy.
Yes.
Okay, yeah. Which is one of the differential diagnoses for what? Constrictive pericarditis is a differential diagnosis for?
Sir, ascites
Yeah,
and
for
low.
chronic liver disease.
Yes,
It'll look like a chronic liver disease
yes,
until you pick up the pericardial rub.
yes,
Okay, yeah, continue.
yes.
So you said it is intact, and you were like halfway, like you give pressure over the abdomen. You said
Yes.
epigastrium fine. So how do you elicit that? What do you expect when you give pressure over the abdomen? For how long do you give?
Sir, for 30 seconds to 1 minute, the
Okay.
JVP, the jugular venous pressurizes and the pulse can be seen transiently. And
It is seen transiently.
yes,
So
sir.
when it persists, then you think of cardiac conditions.
Yes, sir.
Right. So what liver condition is this relevant? Abdominojugular reflex.
Sir, Bachchari, sir, there will be absent abdominal jugular.
So yeah, so when they are absent, then it means that the patient may have a Budd-Chiari syndrome, or what is the pathology in Budd-Chiari syndrome?
Hepatic vein thrombosis.
So hepatic vein outflow obstruction or hepatic vein thrombosis, where the pressure is not transmitted
through the
across the
IVCs.
liver into the IVC. So
Yes,
yeah,
sir.
agreed. So again, might be a little out of the way, but this abdominojugular reflex or hepatojugular reflex is again a controversy. This happened to me when I said abdominojugular reflex. My examiner didn't agree. You should say, he mentioned that you should say it is hepatojugular reflex.
Okay, sir.
The main reason why we avoid pressing over the liver is it might be tender, especially in conditions like Budd-Chiari, where we all the more want to elicit.
Yes,
So that is why some books say you do an abdominojugular reflex, and if I remember it, I think you press over the epigastrium. In the periumbilical region, not epigastrium.
Okay.
Refer that once. Okay.
Yes, yes.
So again, this is a few questions about hepatojugular reflex or abdominojugular
Dr.
reflex. Okay.
Karthikeyan,
Yeah.
can I
Proceed.
intervene a moment? Dr. Karthikeyan, can I intervene? Yeah.
Sir.
Yeah, regarding this abdominal reflex,
Yes, sir.
conventionally the area of examination or proceedings over the periumbilical region, but the current
Yes, sir.
concept of demonstrating or eliciting the principle of abdominal reflex anywhere over the abdomen, not necessarily epigastric, not necessarily right hypochondrial, not necessarily periumbilical region, should be able
Okay.
to make the movement of blood column within this IVC to the intrahepatic route and going to the jugular venous. So it has been
Fine.
considered
Okay.
that technically speaking, it should be able to make the movement of the blood column and not necessarily periumbilical, not necessarily epigastric. But
Epigastrium.
exam
Fine, sir.
point of view, exam point of view, periumbilical is the ideal side, epigastric also acceptable, but not over the right side. Because of the reasons what you said is
Yes.
absolutely correct. Number two is the current the textbooks of clinical medicine also agreeing that it is no more called as hepatojugular reflex. It is an abdominal jugular reflex. The controversy goes on between the previous generation examiners and the current generation examiners, but doesn't matter. The student is not going to be penalized for this statement. That's not a big deal at all.
Okay, continue, Dr. Sweta. Next slide.
Yes. The height 165 centimeter, weight 75 kg, corrector weight is 60 kg, and BMI is 22 kg per meter square, and mid upper arm circumference is around 24 centimeter, and hand grip is 100% in bilaterally. Signs of liver disease: leukonychia plus in and spider navy plus 2 in number found in the upper chest wall, sparse axillary, testicular and chest hair plus, and alopecia present, no pruritic marks, no temporal halying, no
1
loss of.
second, Dr. Sweta.
Yes, sir.
What is spider navy?
Sir, it's in the central arteriole. With peripheral branches of vessels.
Yeah, it's got radiating branches.
Yes.
What is okay? And one more thing is, how much is considered significant in spider
Sir,
navy?
more than 5, sir.
More than 5. What is the differential diagnosis of spider navy?
Sir, telangic tissues.
Eh?
Hereditary telangic tissues.
No, Campbell D. Morgan spots, which are hemangiomas,
Yes, sir.
or there's something called venous star, which goes up in venous pressure elevation.
Yes, sir.
Okay, and the sparse axillary testicular gesture, what can it indicate?
Sir, low testosterone levels.
In other words,
or
what's the
hyperestrogenism.
hypogonadism.
Yes,
Or
hypogonadism.
because of hyperestrogenism.
Yes.
What is this alopecia?
Sir, loss of patch of hair.
Okay, hair loss. What are the types of alopecia you know of?
Sir, alopecia areata.
Yeah, correct. Then alopecia androgenic. Androgenic alopecia is male pattern baldness.
Yes, sir.
And cicatricial alopecia, which is all scarring.
Yes, sir.
Okay,
Secretary,
continue.
yes.
Continue.
No
So
loss.
just one question, one more question, sir. You said spider nevi more than 5 is significant. Any other clinical relevance for spider nevi you know of, ma?
Sir, spider.
You said more than 5 is significant.
Yes, sir.
Anything in the number that you should be following up, or what is the importance of knowing spider nevi?
For decomposition, patient is going for.
In other words, these are all signs of not liver disease, signs of liver cell failure.
Yes,
So
sir.
when you're seeing a patient routinely, when the spider nevi are increasing in number for some, when we're examining,
Yes.
so it means that the patient's liver function is declining day by day. So you should
Yes.
prognosticate. So it is a prognostic marker.
Yes.
Okay, and when they're disappearing, if you count them even in an OP sitting, you can see when your patient comes after 2 weeks, you find the spider nevi, they are lesser in number. Then it means that the liver function is actually improving, liver is regenerating. So this is one of the the signs of liver cell failure, which has a very clinical relevance rather than your androgenic, alopecia or your leukoplakia. This is one finding which has importance. So you should always know to count your spider nevi. You can, if the patient is in the ward, you can even do it daily and you can note it down. If it is going up, it's better to prognosticate. Patient might be looking stable, but it means that he's underlying, is declining, going to decline in the recent future. So that is one thing about spider nevi. And a few points about this. Any of this, like sir asked, any of this the patient can, the examiner can go into and ask in detail. So how do you elicit flapping tremors? Why do you get pelvic swelling? Why do you get palmar erythema? So just know at least two points for each of them, so that you'll be able to answer, and that you can move on to the next question. Okay, so just basically 2 points. Why is it happening? What is the mechanism? And what is the clinical importance? Like we saw for spider nevi. No, at least 2 points for all of them, so that they can ask anything which you can answer. Okay, fine. Go ahead now.
No loss of buccal pad of fat, no flapping tremors, no paratidomegaly and gynecomastia, no testicular atrophy, dependence contraction, no palmar erythema, no subconjunctival hemorrhage or bite spots, no fetal hepaticus, no ecchymotic patches or tattoo marks. Per abdomen examination on inspection, the abdomen is uniformly distended with flanks full, all quadrants moves equally with respiration, umbilicus is everted and in midline shifted downwards. The skin over the abdomen shiny and stretched, prominent veins present over the upper abdomen, no divergence of recti, hernial orifices were normal, no visible peristalsis or pulses, no fullness in the left supraclavicular fossa.
One second, doctor.
Yes.
Can you describe the veins in detail? Upper abdomen veins. There's no veins along the umbilicus and the flanks.
Sir, the upper abdomen veins were more prominent, sir. There are very small veins in the flank region, sir, but not that much prominent.
So why do you think the veins are relevant?
Sir, to see any portal hypertension and SVC or IVC obstruction.
What is that veins around the umbilicus called?
Sir, caput maris.
What is the medusa they're talking about?
The veins around the umbilicus.
What does the word medusa mean? What does the word medusa mean?
Say collaterals.
Medusa is a Greek mythological character.
Yes, sir.
Whose head was like snakes, a lot of snakes. If you look at the Medusa, it'll get turned into stone. So that's why it's called Medusa, because it's got this hair like snakes, and that's how veins look like.
Yes,
So if you were to find veins in the lateral chest wall or paraspinal region, what are you thinking of?
sir. IVC obstruction. Budget.
So how do you differentiate IVC obstruction from an SVC obstruction?
By milking of the veins.
Can you elaborate on that in detail?
Sir,
In what position?
sir, we should select the
In what position of the patient?
sir, in standing position, sir.
Always in standing, yeah.
Yes, sir.
Can you elaborate further?
In standing posture, the most prominent vein without branches was selected, and using the both index finger, the vein is milking of the vein was done, and we should remove one finger, and see the fast filling of the blood, direction of fast filling of the blood. In SVC, the blood fills from above downward.
See, what happens, what you said is correct. You milk the vein and release one finger, and you know the speed of filling.
Yes, sir.
If the speed of filling is faster from below upwards, it's IVC obstruction. If the
Yes, sir.
speed of filling is faster from above downwards, it's SVC obstruction.
Yes, sir.
But it happens in a fraction of a second.
Yes, sir.
So I think the observation has to be very precise, and we have to have a lot of focus. Dr. Karthikeyan?
Yes, sir.
Yes, sir. Yes, sir. Like sir said, the position is important, and
Yes.
the way you elicit,
Yes, sir.
and the direction of filling, and the rapidity of filling, all that is important.
Yes, sir.
So the factual question will be, what is the anastomosis which happens in IVC thrombosis? You know, Dr. Sweta?
Sir?
Which veins get anastomosed?
Which vein becomes prominent, in other words? What is the connection which becomes prominent?
Superficial epigastric and superficial circumflex with the lateral thoracic vein.
Okay, sir.
Okay.
Yes, sir.
The blood flow pattern, mind the three conditions: SVC obstruction, portal hypertension, and an IVC obstruction when it comes to the abdominal wall veins.
Sir, in SVC, the blood flow will be from above down.
Yeah. Okay.
Above downwards, sir. In IVC, below upwards, sir. In portal hypertension, away from the livers, in the upper
away
abdomen,
livers.
livers.
Away from the. Is it liver or something else? It's away from the umbilicus.
Sorry, sir. Away from the umbilicus. Yes.
In case of portal hypertension. Okay.
Yes.
Yeah, continue.
What's the normal direction of flow, Dr. Sweta? Periumbilical region, what is the normal direction of the flow? Blood flow, venous.
Normal.
No, what is the normal direction?
Towards or away?
Away from the umbilicus.
So basically, portal hypertension blood flow is an exaggerated normal flow.
Yes, sir.
Okay.
Yes, sir.
Yeah, continue.
Palpation in supine and standing position. Superficial palpation, no warmth or tenderness, no guarding or rigidity, hernial orifices are free, no renal angle tenderness. Measurements, abdominal girth was around 1 or 2 centimeter. Left spino-umbilical distance is 24 centimeter. Right spino-umbilical distance 24 centimeter. And xiphisternum to umbilicus distance is 26 centimeter. Umbilicus to pubic symphysis is 16 centimeter. The direction of blood flow in veins is the direction of blood flow is faster in the direction away from the umbilicus, and On deep palpation, liver not palpable, splenic notch palpable at the left costal margin, kidney not palpable, left supraclavicular fossa, no nodes palpable, and the spine is normal. Parectal examination, no skin tag or external hemorrhoids present, normal sphincter tone, no Melnick stools and no fissure. On percussion, upper border of the liver dullness felt at the fifth intercostal space in the mid-clavicular line and confirmed by tidal percussion. Lower border of the liver not palpable, and by percussion, the liver span is around 10 centimeter, and splenic percussion by Castell's method, dullness is observed in the eighth intercostal space of anterior axillary line during inspiration and resonant
Okay,
on
one second. What is your comment on the liver span?
Sir, it's normal levels.
What is the normal liver span?
Sir, it's less than normal level span is 12 to 14, sir.
So what is this?
Less than normal level span.
So what does it mean?
Cirrhosis.
Cirrhosis. So
Yes.
yeah, so it depends on which book. Different books give different
Yes, sir.
numbers,
Yes, sir.
but you should quote the standard book.
Yes.
So can you describe Castell's method?
Sir, in the anterior axillary, left anterior axillary line, at the lowest point of intercostal space, we should
Which space is that?
eighth or ninth intercostal space. We should percuss for we should percuss for dullness. Usually in normal spleen, on full inspiration and expiration, there is a resonant on percussion. In mild splenomegaly, on full inspiration there will be dullness, and on a full expiration there will be resonant. And in moderate to severe splenomegaly, on full there will be dullness on both full and full
Okay, good.
inspiration and expiration.
Okay, what is Nixon's method?
Sir, in the midpoint of the lower costal margin, we should percuss.
How do you determine that? How do you determine the midpoint of the costal margin? So you'll have to use a measuring tape approximately, and you'll have to mark the point.
Yes, sir.
And then you'll percuss towards where?
So perpendicular to the
Up to what line you'll percuss? Posterior
Sir,
axillary line.
yes, sir. Posterior
In
axillary.
Castell method, it's anterior axillary line. Here, it's a posterior axillary line.
Yes.
Beyond how much is the spleen enlarged?
Beyond 8 centimeters.
Beyond 8 centimeters, it's splenic enlargement.
Yes.
What is Middleton's maneuver?
Sir, in the right lateral position, we in the right lateral position, we should stand on the left side facing the foot. We by hooking method, we should feel for the spleen edges.
Yeah,
Sir.
you just have to hook your left hand under the costal margin. It's among the few, maybe the only thing where you stand to the left side of the patient.
Yes, sir.
No, just a correction here, Dinesh and
Yeah.
Shweta. It is not a hooking method to be followed for Middleton's maneuver.
Yes.
It is basically asking the patient or examiner to keep his fist of his patient's examiner or the patient on the back of the left side lower thoracic wall, or the area what we are discussing as the anterior maxillary line, mid axillary line, posterior axillary line. And the examiner can be standing on the right side and try to insinuate your finger while
Yes.
the patient is pushing from the back, and
Yes.
deep inspiration is able to get the following, the able to palpate the spleen is the method of Middleton's maneuver.
Okay.
But it is not a hooking method. It's not a hooking method. Hooking method is different.
Yes.
For hooking method, you're supposed to stand at the left side of the patient and put your fingertip inside your left costal margin
Yes.
and try to deep inspiration. Can ask the patient to cough also. can look for the very, very small size spleen where you're trying to look for. Whereas middle tense maneuver is making a fist and pushing from the behind and try to palpate, standing on the right side of the patient and putting your finger or hand as usual method of from the right iliac fossa to the left costal margin. Try to palpate is the way to look for the middle tense maneuver.
Yes.
Yeah, thank you.
Now you can continue.
Yes.
Dr. Shweta, I have few questions on the percussion.
Yes.
So, sir, this is for I'm asking both Savan sir and Dinesh sir. So, her findings mentioned that there is fluid thrill. So, which means there is significant fluid in the abdomen. Can you just go back, ma? Go to the previous. Let's see. Show your yeah. So, and you clearly mentioned that the lower border of the liver is not palpable. So, technically speaking, you should say that you were not able to make out the liver span.
Yes.
Okay, so you are able to make out the upper border, but lower border, because of the fluid as such, you're not able to make out. So I think it would be better if you say you're not able to make out the liver span.
I have a
If
question,
there
Dr.
was-
Karthikeyan. I have a
Yes,
question. If you can't make out the lower border, can't you just calculate the distance, whatever, up to the costal margin and say it as a liver span?
if there was no fluid, sir, then maybe you can take the costal margin as the lower border. But with fluid, when you're not sure that the liver is, that is, we are not able to make out the lower part of dullness at all with fluid. So in that case, I think we're justified in saying I'm not able to make out the liver span because there is fluid in the abdomen. So there is no dullness in the lower part at all.
Okay.
I think
Okay.
that
No,
will be a
but exam,
better.
yeah, exam point of view, Dr. Karthikeyan, I
Yes, sir.
might slightly disagree with your point of saying that because sometimes they will get into the problem. When I say
Okay,
you
sir.
are not able to measure the liver span, definitely the postgraduate will be bombarded with the question, how can you do
Questions.
that?
Okay, sir.
Definitely, it's a practical difficulty is there. That's a probably
Okay, sir.
division level. It may not be that much depth.
Yes,
or
sir. I think that's the small
examination.
difference. Or
Yeah.
what you can say is lower border of liver not palpable. So maybe you can take the the right costal margin itself as a lower border. And from that you can mention.
Yeah, liver
So
span
maybe you can put
examination.
it that way.
Yeah, liver span examination is technically speaking the 3 steps. It's a percussion palpation method or palpatory percussion method. So in that case, we're going to percuss and we're able to appreciate minimal amount of dullness in the lower part of your costal margin. You say to the examiner, since you're not able to palpate the liver, acceptable, but at the same time, you're able to demonstrate minimal dull note in the lower margin, in fifth space or fourth space or fourth rib or fifth rib, whatever the space you're going to look for it. You try to tell the examiner liver span is this 10 centimeter, 8 centimeter. Without
Dr.
saying
Thakur, but
number.
what Dr. Karthikeyan is telling in the presence of fluid. So in the presence of a lot of fluid, tense
Yeah,
aside
in the presence of fluid, I'm talking about in the presence of fluid only. You will
Yes.
be able to, because the fluid is not disturb your percussion note over there. Even the significant note, significant fluid connection, it may not be. Because most of the time the fluid is not placed over there, technically speaking. So in that case, you'll be able to demonstrate definitely dull note over the costal surface. I'm talking about right side costal surface. So
Right.
whatever is there, because they're not going to verify that. What I'm telling is, if you're not going to say at the MD level, on the undergraduate level, liver span I'm not able to measure because of this. And I would say like 75-80% time will be in trouble. To avoid that confusion, not for DM level, definitely. So in that case, go smooth sailing or you are without any hassle, just go for this method of examination, tell the finding, you'll be in a safe side.
Okay. Dr. Sweta, go back to the previous slide, percussion slide.
Yes.
Okay. Have you mentioned the shifting dullness?
No shifting dullness, sir. Fluid thrill is present. Like as it is.
In that case, doctor, your first line itself can be I'm able to make out a dull note throughout the abdomen.
Through yes, sir.
I think that will be better. And then you mention in that there's fluid.
Yes.
So, and again, I have a doubt, sir, because sometimes they say fluid thrill should come in the palpation because you're not
Yes, it has
actually
to come in
percussing, you're just
palpation.
tapping. Yeah, so that is one doubt which I have. I mean, even in our exams, we tend to make this mistake. So I think it would be better the exam. I mean, the candidates have a clear either should we mention in the percussion or in the palpation itself, sir?
Yes, yes. No, I would say palpation and percussion will be shifting dullness. That's how we have been doing it.
Fine.
Okay,
So please change the Dr. Shweta. I think fruital can be mentioned in the palpation itself if it is present. If it is not, then you can mention in your percussion whatever finding you're eliciting.
Okay, sir.
Yeah, continue,
Okay.
continue.
Yeah, and few things before we move on. So just few more questions here, sir. We talked a lot about liver span, right? Why is it important? Why is the liver span so important? One thing is, it goes to saying if it is shrunken, then it means that the liver is a cirrhotic liver. Any
Yes, sir.
other conditions where the liver span is very important?
Sir, hepatocellular carcinoma.
Okay, that is like a different way. You find an enlarged liver, but you have features of cirrhosis, then you think of a hepatocellular carcinoma. Any other place where measuring serial liver span is important? I'll put it directly like this.
Hepatitis.
Sorry, yes.
Sir,
Yes, tell me, you're right.
congestive hepatomegaly, sir.
No, you said acute hepatitis, right?
With diuretic therapy, the liver span
Ma,
might.
1 second. You said acute hepatitis, right? Dr. Shweta?
No, sir. Congestive hepatitis.
No, ma. My question is, you told acute hepatitis or not?
Sorry, sir.
Okay, let me go back. Why is any other condition where you serially
Sir.
will measure the liver span?
Hello, sir.
Any other condition where you will serially measure the liver span, and it is important to measure every day. You
Sir,
measure
congestive hepatomegaly, sir.
No, that is not the answer.
It's not acute, doctor. Acute conditions are is talking about hepatitis, what it can lead on to, drug-induced problem, inflammation or infection related. We are supposed to examine the liver span on a regular basis and on a daily basis. Suppose patient's liver span is decreasing while examining the patient.
So
Seventh day,
you
eighth
find
day.
what does it imply?
Okay, patient's conditions are deteriorating in the form of hepatic encephalopathy, worsening jaundice.
Sorry.
I think you're not taking our dinner, doctor. That's a big problem. Brain is not working.
I think we pushed the thresholds. So let me answer that. In acute hepatitis, more so in case of acute liver failure, when you have an enlarged liver initially and on examination, it starts shrinking or suddenly even in 1 day it suddenly decreases. It means that the liver has gone for necrosis, massive necrosis, which is not a good clinical sign. Patient may worsen any time.
Yes, sir.
So that is why this liver span is so important.
Okay, sir.
Okay, if it is a frank cirrhotic patient, then it's not an issue. But otherwise, why this liver span is so important is in other acute conditions, especially in ALF, you have to measure serially. Of course, now we do the liver function test and it is even ready before you go and examine. But still, when that facility is not there, or when you don't have the time for all that, or when it's getting delayed, then you go clinically with the liver span. That is very important. That is why you should be thorough with the liver span. Okay?
Okay, sir.
Yeah. So again, this drop space, my one doubt, sir, with fluid, can we still say if it is subject and could that be because of the splenic enlargement, sir, with fluid being present?
Yeah, it could be difficult. It depends on the extent of fluid. If it's a massive ascites, yes. So it's very tough to substitute.
With fluid thrill in this patient, I think this orbital drop space and this calcium the dullness, I don't think it will mean that the spleen is enlarged. So in this case, it is difficult. Maybe because there's a shifting dullness and or even if it is not present, then maybe you can think of an enlarged spleen. And sometimes they can ask about pulsing. Just know how you should tell in the exam. You should know how to tell. You need not demonstrate because it's technically difficult to make the patient in the near proportional, but you should know how to tell it properly. So please rehearse that properly. You should not
Yes.
fumble in the exam. Okay.
Okay, sir.
One more thing, Dr. Karthikeyan, it depends on which day they'll see the patient. If it's day 1, there could be volume overload. If it's day 8, day 9, with a lot of
Yes, sir.
diuretics, the arthritis could
Yes,
be
sir.
coming
Yes, sir.
down.
It depends. It changes, sir. So that is also there. So again, see, most of the times the examiners may not go and examine, but when they have a doubt and when they examine or when they ask me to go and examine once, make sure you do it properly.
Yes, sir.
Okay.
Okay, sir.
Yeah, continue, Dr. Swain.
Yes.
Okay.
On auscultation, bowel sounds present, no venous hum, bruit, or rub. Other system, CVS is normal heart sounds heard, no murmur. Respiratory system, bilateral, normal vesicular breath sounds heard, no added sounds. In CNS, patient obeys commands, moves all four limbs, bilateral plantar flexor, no cerebellar signs, able to draw a 5-point star, and psychometric test, number connection test was done in 25 seconds. Fundus examination, normal.
Continue.
Again, is fundus examination mandatory, sir, for liver patients? Should they
Which
mention
one?
that?
Fundus,
Fundus.
I
Yes,
think
sir.
at PG level they have to they have to at least have the retinoscope.
No,
They
sir,
have
for
to
an
have it.
abdomen case, even if, I mean, all the more
Not
when you know it's
required.
liver
Not
disease,
required. Abdomen case
yeah.
not required.
Yeah, fundus examination, I think you can skip because, again, let us not invite more questions with that.
Okay.
Okay.
Yes.
Other things agreed, yeah.
Okay.
Okay.
And you mentioned flapping tremor in the signs of liver disease
Subflavus,
now, but
yes, sir.
make sure you mention it again here because sometimes they might have missed that. You can't say, sir, I mentioned that.
Yes,
So
sir.
mention it here also.
Okay, sir.
Okay.
Okay, sir.
Yeah. Again, flapping tremor is an entire topic for discussion. How do you elicit? What is the mechanism? What is the axis involved? Any 2 or 3 lines you want to tell about flapping tremor because it is very important, right? How do you elicit flapping tremor?
With the outstretched and with dorsiflexion of the wrist, fingers separated, sir.
You ask the patient to hold in that position,
Yes, sir.
right?
Yes, sir.
So what happens?
Sir,
Yes.
Unable to hold the position, doctor.
Unable to hold
Patient
the
can't
position,
hold.
sir.
Lapse of posture. That is how it is
Yes, sir.
defined. Asynchronous lapse of posture. Patient won't be able to maintain that position.
Yes.
Fine. So this is enough. But again, they might ask a few more questions. So read about it. I want to go into detail of that, but read
What
about
is
it.
the
Fine. Okay.
neurological term for this asterixis?
Sir, negative myoclonus.
Good. Yeah, correct. Continue.
Diagnosis, decompensated chronic liver disease with portal hypertension, probably ethanol related, decompensation in the form of ascites and jaundice. No evidence of complications such as spontaneous bacterial peritonitis, hepatic encephalopathy, or other complications like hepatorenal.
Go back to the previous slide, doctor. Above. So, how do you explain the respiratory distress? You spoke about patient being breathless. Is there any evidence in the other system examination for the respiratory distress? Or what do you think? The patient's respiratory rate you printed as 22, but there's no explanation here.
Yes, sir. No, there is no reduced breath sounds, no evidence of pleural effusion or hydrothorax.
Okay, so the patient is breathless because of
Ascites.
ascites. Okay.
That's.
So one more question about this respiration, sir. I remember you telling it is abdominothoracic, right, ma, in the general examination.
Yes,
and
sir.
you mentioned that there is fluid, which means there is tense ascites.
Yes.
So with tense ascites, you still think the respiration can be abdominothoracic? So I think I'm asking this question to you also, Dinesh and
General thing what
sorry,
says
sir.
men abdominothoracic, women thoracoabdominal. I mean, that is the general
Yes, sir,
teaching.
yes, sir. But with tense ascites, can we still say that the patient still has abdominothoracic type of breathing with ascites, sir? Is it possible for them to say? Because
by convention, that's how it's mentioned. Dr. Sandan, do you have any views on this? we just follow the
Yeah, yeah.
conventional method.
Yeah,
I mean,
No,
we need to check
abdominal
whether
jugular, abdominal breath, means abdominal thoracic breath cannot be mentioned in a person with huge ascites. Very difficult to appreciate. You don't get that as a dominant pattern of breathing pattern from abdominal thoracic, even ascites patient. It's a male or female gender. You don't.
I think that you can slightly modify in the presence of tense ascites. I mean,
Yes, sir.
you have examined and only your present is. So even if you initially feel it's abdominal thoracic, in the presence of tense ascites, you can modify it later and mention it as thoraco-abdominal type.
Okay, sir.
Okay.
Yes.
Yeah. Proceed. And SBP, I don't think we have any clinical evidence for SBP. Must think you can skip that. You
Yes,
can
sir.
say hepatic encephalopathy aggrade and SBP. Clinically, there's no. I mean, of course, there's no pain, but I don't think it's a clinical diagnosis SBP. So I think you can skip that part.
Okay, sir.
Okay. Yeah.
Yes.
Proceed.
On investigating, hemoglobin is 13.3, MCV 103, WBC counts are 7,900, and platelets.
Doctor, just 1 minute. Sir, just for want of time, should we go into elaborate investigations or something relevant? What all she wants?
we will
What
just
shall we?
only the key findings alone.
Only 10 more minutes, Dr. Karthikeyan and Dinesh. 10 more minutes.
Okay, Dr. Sweta, what is your quick comment on the CBC?
Sir, there is a macrocytic anemia, sir.
Okay, what do you think that's due to?
The alcohol related.
So what deficiency can be there? Or is it primarily due to alcohol or something else?
Sir,
Okay, one is
vitamin deficiency, sir.
What vitamin?
Sir, that B12.
Okay, B12 folate.
Yes, sir.
Okay, then continue. Urea creatinine? No, go. Urea creatinine. What is your comment on urea creatinine?
Urea creatinine. Urea was slightly increased, sir. Creatinine was in the normal range, sir.
Okay, your comment on the electrolyte?
Electrolytes were in the normal range.
Glucose. Okay, next.
Yes. Patient is having direct hyperbilirubinemia. More of, and SGOT is more than the SGPT.
So what does it indicate?
Sir, more of alcohol etiological.
Alcohol liver disease. Okay,
Yes,
and then proteins.
So protein is 7.3. No. Albumin is 2.9. Hyperalbuminemia present.
What does it indicate? Normal liver.
What term you mentioned for this, ma? When the albumin is low, in this case, what do you call it?
Age reversal.
So you can briefly say more of indirect hyperbilirubinemia, AST more than ALT with AG reversal.
Yes.
So that is your LFT interpretation for this patient. Okay.
Yes.
Yeah. Okay. And then PT, prothrombin time.
Sir, PT is prothrombin time is 14 and INS is 1.27, sir.
So what's the interpretation?
Mildly prolonged.
Mildly prolonged, sir.
Okay, then acetic fluid.
In acetic fluid, total count is 240, sir. Albumin 0.97 and protein is 1.
What is your interpretation from this?
No SBP, sir.
Okay, anything else?
Neutrophils also?
Sir, yes, sir.
Ideally, you should mention the percentage also. I don't think it is there, but anyway, the overall count itself is only 240, so it is assumed that the neutrophils are going to be less. But ideally, you should mention TC and DC.
Okay, sir.
The differentials in the acidic, that's how you commonly see in our wards, right?
Yes.
You measure the differential count as well in the acidic fluid.
Yes.
What else information you have from the acidic fluid?
Sir, the protein
how
is
the
yes, sir. The high sag.
High sag and what else? What else?
Low protein, sir. High sag,
low protein ascites with no evidence of SBP. Culture is also sterile. Fine. Okay.
Yes, sir.
And initial patients, always remember, do cytology for all of them. You never know which patient will turn out to have some underlying malignancy. It
Okay, sir.
you might clinically suspect 100% liver disease, but initially at least once do cytology for all of them. Don't hesitate, because
Yes, sir.
many a times we pick up atypical cells in the cytology itself. Sometimes if you'll be finding in our wards, even in the total count, they sometimes mention as atypical cells.
Yes, sir.
So at least once any ascites patient should have had a cytology done.
Okay, sir.
Okay.
The DNA profile was negative, and the alpha fetoprotein was in the 2.6, and ceruloplasmin is 16. IgG immunoglobulin is 16.25, and 24 hours urine copper is 73 microgram, and serology was negative. And UGScopy, grade 1 esophageal varices was seen, and severe portal hypertensive gastropathy is present. And CT abdomen, chronic parenchymal liver disease with gross ascites and mild splenomegaly presence.
Why
A
do you
comment
think
on the
patient has undergone a
ceruloplasmin level? Ceruloplasmin level comment.
Sir, ceruloplasmin is low normal. More than 20 is normal.
Yeah, it's like ceruloplasmin like urea. So this would be low ceruloplasmin.
Yes, sir.
24 urine copper levels.
This is in intermediate range. More than 100 is significant.
Dr. Karthikeyan, your comments upon the ceruloplasmin and
Yes, sir. So ceruloplasmin, most often we do this as an initial screening test, and in many patients it turns out to be lower than the range given, but we find that it is like something like a negative acute phase reactant where it goes down in acute conditions. So,
right.
like what we've done, we have to confirm with the urine copper. This is intermediate because the cutoff is less than 60. We rule out. More than 100 or 150, we confirm. But in
Right.
such borderline intermediate cases, we
Slit
go
lump
for something called
examination.
yes, that is one thing, sir. We also go for a penicillamine challenge test. We challenge
Okay.
2 doses of penicillamine and see if the urine copper is going up. If it is going up more than 200 or 150, then it confirms.
Okay.
K-ring only in 30%. So if it is present, then it can be taken as an evidence. But absence still doesn't rule out Wilson's disease.
Right. Okay.
So the take home from all of this is, even if we know the patient has had significant alcohol intake, please work up for other causes also, because we do end up finding out some other conditions which we can treat. Sometimes they may become abstinent, but still their liver disease starts progressing. So if we are able to find out some other reason, and if we treat that, there's a good chance he might improve, especially being a very young patient. So maybe around up to 60 years also, we are justified in ruling out other conditions like autoimmune hepatitis and Wilson's. Hemochromatosis, we don't find much in our population, so because ferritin is a very non-specific marker for inflammation. We
Right.
find it more, I mean, it being elevated in other inflammatory conditions also, like even in NFL, it can get elevated. So that is
Right.
not very relevant, but at least these two we can do for all patients. Additionally, thyroid and lipid profile also, sir,
Right.
as
Right.
part of the etiological workup.
Yes.
Yes.
So the only thing is, what was the duration of alcohol history, Dr. Sweta?
Sir, for 7 years, sir.
So 7 years and ending up in a chronic liver disease, huh? And
Yes,
with recent increase in alcohol intake in the last 1 or 2 years.
Yes, sir.
Okay, that's a rapid progression, Dr. Karthikeyan.
Yes, sir. But one thing which is surprising us is bilirubin is only 3, sir. So from your history, I expect it to be at least or around or 8 or 10 or something like that. So that is something which is not fitting in. So I think he has a more phenotypic presentation of a volume overload rather than the acute part, like in the ongoing activity in the form of jaundice. So I think he's that phenotype. So that was one thing. And when you tell all the more for 6 months with CAM intake and recent alcohol intake, I expect the bilirubin to be higher. So I don't know how his presentation is a little different. Again, each patient is different. So we don't know.
Right.
Yeah.
So, Dr. Sweta, we won't go much into management.
Yes,
If
sir.
there's one intervention you could do to prevent a future worsening of liver disease, what would you do?
Sir.
His
So,
serology is negative.
yes, sir. Alcohol abstinence.
I'm telling you a clue. His serology is negative.
Yes, sir.
What will you do? on intervention?
Sir is asking, you want to prevent
Yes,
first future complications or progression, and
yes,
sir
sir.
is mentioning serology is negative. So in this,
Sir,
what do you mean by I think you presented this in one of the discussions, right? I'm giving you one more clue.
It's vaccine. What vaccine will you give?
Oh, yes, sir. Sorry. Hepatitis B vaccine.
Yeah.
She presented C that time, so that's I think she doesn't know B.
Okay.
Yes,
Dr.
Okay.
Sandan, can we wind up? It's 10:20.
Yeah, it can. I think we have come to a very good conclusion and discussion on this aspect of liver disease. But Dinesh started with all basic questions and very important also essential part of knowing about this, because exam point of view may not be knowing when the exam is deviating from the conventional way of asking the questions. Sometimes might get deviate. So in that case, if you are a postgraduate, if you are not able to answer those questions, very basic questions, then you'll get into the problem. It is not necessarily always expecting that they're going to ask about only the management. Probably this type of experience only for the DM exam, not for the MD exam. So it can be middle zone, can get into trap anywhere. And always try to present Dr. Shweta, that is my opinion. And
yes, sir.
the other faculties also can give their input regarding the quality of presentation. A bit of low volume and bit of hesitation of your expressing your views.
Yes, sir.
It is always try to make your presentation more frequently. You'll get the flow of presentation. It is
Okay, sir.
more important if you have the confidence, you'll get the more flow. So sounds to me more of lack of confidence, maybe because you're not attempting to present, volunteering yourself to present, that might make your confidence to go down. And it is doesn't matter at all. These are the platforms basically meant for to have the open mind and start presenting without any hesitation. Make your all mistakes here so that you don't make mistakes in the final day of your examination. That's my opinion to you and suggestion to you. Try to change your way of presentation. Definitely you'll be able to answer the questions much better. Even if you're going to make mistake here and there, the flow makes or patch up work, better patch up work.
Okay,
Okay.
sir. Okay,
As
sir.
Chatin and Dinesh can give your input to make our presentation much better than what you want.
Dr. Sweta, before the presentation, you must rehearse at least 10 times.
Okay, sir.
Practice, 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 practice until you get the flow. 10 times, 12 times. Keep on practicing until you get the flow.
Okay, sir.
And at every step, try to anticipate questions.
Yes, sir.
And as Dr. Karthikeyan clearly mentioned, for every point you speak, you should have 2 or 3 points ready.
Okay, sir.
Everything that comes out of your mouth, anything that's on display, you have to have 2, 3 points behind that.
Yes, sir.
You know, after so many presentations, what are and I suggest when you hang around, when you present to consultants, don't note the points, note down the questions. You need to create a question bank.
Okay, sir.
Okay, so now all these questions, you just collect these questions and keep preparing for them. When you present to 5 different faculty, you'll get 5 different question banks.
Okay, sir.
And invariably, most of it will come from that.
Yes, sir.
So one, rehearse 10, 12 times. Number 2, collect the question bank. And then invariably, most of the questions will come from that.
100% will come. Not most of the time, 100%. Because
Yeah.
if you're going to listen to 5 examiners and definitely will be able to cover up, nobody's going to go beyond that level. Definitely. That means the answer means questions are leaked out. That's all, very simple. All the questions are leaked out, practically speaking. It's only the way of discussion, but the initial part should be very clear about knowing the answers for individual simple questions. Dr. Karthikeyan, please.
Yes, sir. Sir, I agree with both of you. So I think I'm just going to repeat a few lines of what
Yeah.
both of you told, sir.
Yeah.
One, you should be more confident and
Yes.
proper sentence formation. Don't just be
Yeah.
abrupt. Have a proper sentence and present it to them. Generally, they'll be happy and they'll know that you have worked well and you can approach the patient. See, we want to know how we are going to go and work after your MD or DM.
Okay,
That is
sir.
what we want to know from the exam. It is not about passing that day. We want to be sure you'll go and work well outside. So have that in mind and always start with basic common answers.
Okay, sir.
That's what I tell my postgraduates. Don't think of complicated things to begin with.
Okay.
Just because on the DM level, think of basic things first. Start with them, then only go to your other. And like sir said, be thorough with your examination way of examination, how do you tell that? Have proper flow, that is more than enough.
Okay, sir.
And abdomen, though we've discussed a little extensively, I think for MD level, it's mostly going to be a short case, but questions can be anywhere. They can still elicit a hypothetical history and ask you. They can ask you to examine. They can ask you points in examination. So for every part, have some questions ready, and also the answers also should be ready with it. And just 2 points, they'll know that you know, they'll move on to the next part automatically. So for that, you should be confident enough and answer correctly.
Okay, sir.
I think that's
Dr.
it.
Sweta?
Yes, sir.
Sorry, Dr. Yeah, continue, Dr.
No, sir.
Sweta.
Anything you want to tell us, like what is your feedback on your presentation today? What do you want to say?
Sir, we'll do better presentations.
Dr. Sweta, one thing I'd like to tell you, the quality of a public presentation depends on the quality of your communication on a day-to-day basis. So what you habitually communicate to faculty, to your PGs above you, below you, to your CRIs comes out in a public platform.
Yes.
So you have to focus on every conversation every day during rounds. When you report to faculty, focus on your communication.
Okay, sir.
And try teaching CRIs. When you teach, teaching is the best form of learning.
Okay, sir.
Just go on explaining points, keep on describing to CRIs. Everything you come across, you encounter, keep on describing it, keep on talking about it to CRIs, keep on talking subject.
Okay, sir.
As you
And I
keep
think
on
now you have
talking,
surplus undergraduates as well. So you find them anywhere in the hospital. So whenever they are there in the world, and see, that's how you build confidence as well. When they ask you few questions, please don't feel bad that you may not know. That's okay. You just tell them, I'm not sure about this. Let me also read and come. We'll discuss tomorrow. Have that attitude. So
Okay,
never
sir.
hesitate. What if they ask me something and I don't know? Don't see. We've all gone through that phase. Even if they ask you something, they also want to learn. So if you feel you still don't know, okay, even I'm not sure, let me go read up and come. You also read up and come. Have that attitude. That's how you learn, and you start communicating as well.
Okay, sir.
Yeah.
I think thank you, Dr. Karthikeyan and Dr. Dinesh, for a wonderful discussion from basics to the clinical examination techniques and the points for the discussion on the different aspects of the liver disease related aspects. And appreciate Dr. Shweta for presentation and try to make this platform as a tool for you to improve and understand your level of your capacity of delivering your content, so that it becomes easy for you to how to build onto this level. And you always do a very good job. If you're going to keep on train yourself for better presentation, next presentation also. And
Yes,
thank
sir.
you every one of you, and good night to all of you. Thank you.
thank you,
sir.
thank you, Dr. Karthikeyan. It was
Yes,
very
sir. Thank you, sir.
interesting.
Thank you, Saran sir and Dinesh sir. Thank you, sir.
Very
Thank you.
interesting, very interactive. Thank you.
Yes, sir. Thank you so much. Thank you.
Thank you. Yeah. Thank you.
Thank you, sir.